You're listening to the Business of Pharmacy podcast with me, your host, Mike Kelzer. Ben and Matt, for those that haven't come across you online, introduce yourself and tell our listeners what we're talking about today.
Matt, I'll introduce you if you don't mind. Matt Coakley and Ben Coakley, and we're two brothers. We have prided ourselves on trying to help pharmacy owners and independent pharmacies fulfill their purpose and their mission. We have launched a new solution called the Pharmacy of Tomorrow.
Ben, you are a marketing guy from Clemson. Matt, you're a finance and accounting guy from Clemson. Did you guys scheme that up way back when to say, let's do this, and then we're going to go to college, and then we're going to end up as a partnership? How did the whole Waypoint form?
My dad, he just wasn't an insurance salesman. When he talked about what he did, he never actually talked about, I sell insurance. He'd say, I go out and I serve people. I find out what they want and I help them get it. And so when Matt and I were starting the thought process to chart our path, our future, he just said, hey, here's an option.
Ben was really the instrumental one in pivoting us specifically towards pharmacy. So part of his marketing background said, we need to write a business plan and really get focused on what we're doing.
How do you guys actually make money at the end of this? And we know it's keeping pharmacies successful, right? And we know that if they're successful, you're successful. But what does your success look like?
We are a wealth management financial services company. So we make money when people use our wealth management solutions. There's a little bit of a nuance to the new thing that we're talking about here, and I'll be glad to explain that after we tell people what the idea is. But what's really interesting about our model, and I really believe we've invented a new way to do financial services. The financial services piece pays us. All of the coaching, the Pharmacy of Tomorrow, all this wonderful intellectual property that we own, you get it just by doing the wealth management stuff with us. I tell people, we're not asking you to spend any more money. So we go to a pharmacy owner and we're like, hey, you can get access to all this. And I'm going to show you how I can do your 401k better than what you have now. So you're going to get a better solution. And you're going to get all this coaching and all these new ideas. And, we do mastermind solutions where we get pharmacy owners together and they collaborate on new ideas. I mean, we're really big into trying to advance this industry.
It's a long-time commitment to raise the value of the pharmacy and their earning value, which then end up helping you.
We're talking about the Pharmacy of Tomorrow program, which is about the business model. But what's interesting, the pharmacy owner of today isn't necessarily programmed to create the Pharmacy of Tomorrow. So think about this. So it's like square peg, round hole. We have a program called the Purpose of Capital. And it's a coaching program designed to create leaders, community-based leaders from pharmacists and pharmacy owners. And there's three sources of capital that we've identified that every pharmacy owner and community pharmacy has. That's people capital, community capital, and financial capital. Think about the PBM game. They want us only focused on financial capital.
Mm-hmm.
Well, What happens is if we're only focused on financial capital, number one, we don't look any different than the CVS, Rite Aid, Walgreens down the street, right? We don't. And they've got more money than we do, so they can just outlast us.
Unfortunately.
What makes pharmacies unique, independent pharmacies, is their relationship with the people in their town and the relationship with that community. So our belief is that we have to focus on the relationships and the community, and then find ways to meet the needs of that community through a new model, which is the Pharmacy of Tomorrow.
Spin it back to answer your question a little bit on how it makes sense for us. So, of course, we have some altruistic reasons why we want to see this happen, but also our pharmacies become profitable. They have more money that they can invest long term with us. Maybe they need some of the other programs that we have as well. But I think that's one of many things differentiates us from a lot of financial guys is a lot of financial people will take interest in your investments because if they grow them, they make more money. we do that as well, and we can show people why we think we do it the best in the world. But we also take interest in their business because we want to help them in their business, help more people in their town, which will in turn spin off more money that they can invest with us as a secondary reason. But that's where the finance piece comes in.
Pharmacy of Tomorrow.
The Pharmacy of Tomorrow, I think what really got it in my head of starting 10 years and working backwards, it goes back to the conference that we went to in March. They have a couple of speakers there. A lady named Treya Clausen that runs a company called Design House Cooperative, I think, or Design House Collaborative.
Collective, there you go. She's Canadian. She's a business coach in a sense, but that's her methodology of thinking is instead of saying, where do I want to be in 2030 and setting out a linear plan of what do I need to do in 2021, what do I need to do in 2023, 2025, and so on, she goes through the exercise of let's put ourselves in 2030 and say, okay, I'm mentally in 2030. What does everything look like? And then work it backwards to get there. So it's a pretty neat exercise to do. And then she brought somebody on stage that she'd actually done that with, and it was a fellow named Chip Wilson, who, if you haven't heard of him, he started Lululemon. And essentially that was how the same thought process he went to build that into a $25 billion company that it is now. So you start hearing people like that talk about planning your future from the future, and it makes a lot of sense.
Is that the Flowered Pants place?
They make yoga pants.
Come on now, you guys. I'm going to call you out on that one. This guy gets up there and said, I'm going to look into the future 10 years, and the answer for 10 years from now is flowered pants. Oh, wait, they're not the flowered ones. That's Lulu something else.
No, you're talking about Lulu Ray or whatever.
Lulu Row. So Lulu Row, I think, is called Lulu Row because it's a play on the name Lululemon. So Lululemon started, gonna get me on the dates, in the late 90s in Canada. And so Chip Wilson, not to go too far down this rabbit hole, but he revolutionized workout gear. They call it leisure athletics, or he basically invented yoga pants.
I'll give you that he was the workout pants guy. I just didn't see the whole flower stuff of Lulu Row stuff.
Imagine you get up there and you're trying to create a future from the future. This concept actually was originated by a gentleman named Steve Zaffron, who owns the Vanto Group, and they do consulting for one of the probably top 10 consulting firm in the country, in the world. And he wrote a book called The 3 Laws of Performance, which we're actually getting ready to start that for our book club. And he's the one that actually created the concept, create the future from the future. And so you can imagine Chip Wilson, who wanted to raise the standards of every individual in the world. Now, how does yoga pants have anything to do with that? Well, from what I understand, is that fed through the entire organization to where even the clerks, were just phenomenal. We can learn from that. We can learn from having this purpose, whatever the purpose is, and how to have that filter through the organization to create this powerful vision for the future. And that's what's happened in our business is we're just extremely clear on what this purpose is and what the vision, what we actually have a 2030 future ourselves, what our company is going to look like in 2030. And we created it from the future.
A pharmacist wakes up 10 years later, 2030, 2031, and they walk into their business. They haven't been in there in 10 years. What's going to throw them the most?
I would say it's not going to be focused around putting the pills from the big bottle into the little bottle. I would say that it's going to be a true service-based model where pharmacy owners are truly focused on patient relationship management. Not pharmacy, prescription, or medication therapy management. Finding out the needs of the actual community and meeting those needs.
You said not medication management?
That'll be a part of it. I mean, listen, it's a pharmacy at the core.
You told me what it's not. So there's not pill bottles sitting around.
I would say there still is pill bottles. You're still going to dispense.
Not a transfer. They're maybe going to be package sized and all that stuff already.
Well, so the idea is we have to have diversified revenue sources that don't all run through the PBM.
Understood. But the question is, they walk in the door of the pharmacy. What's going to floor them? What are they going to be thinking when they walk in there? What's going to be like, whoa?
I think what they're going to be thinking is, never in my wildest dreams did I ever think I could create what I'm looking at.
What are they looking at, though?
I think they're looking at a suite of offices with professional people in there. I don't know, like they're going to be in suit and ties or anything like that. But I think they're looking at an insurance agency. They're looking at a home health care agency. They're looking at a hospice company. They're looking at a home remodeling business. They're looking at a nurse practitioner who can actually see patients.
This is what you were talking about they're going to get into the community. Okay, so I'm following now. So their building is going to have these professionals in them.
Yeah, absolutely.
Our vision of the 2030 pharmacy, or the pharmacy of tomorrow, is that it is a center of commerce and a center of healthcare commerce for the entire community.
Oh.
It doesn't replace the actual business of pharmacy, practice of pharmacy, but there's a lot more to it than just dispensing medications.
Devil's advocate. So we've got this building, and let's say it's, 5,000 square feet, and every little office has, a few hundred square feet or something like that. So let's say there's 8 different office things in there. Why does the pharmacist have the audacity to say, I'm going to run this, and this whole thing is going to be called a pharmacy? Or do I have that wrong? Or is just one of the offices called a, quote, pharmacy, and the other 8 are part of this neighborhood service center, so to speak?
Community health hub.
Community
hub. I mean, it's a community hub. I mean, that's what it is.
So it's not a pharmacy they're walking into. They're walking into a hub.
They're walking out to a hub. Yes, sir.
Came up with this a long time ago, but the number one problem that businesses have to solve is you have to get customers. You have to find somebody in which you can sell something to, or you can bring a product or a program that's going to improve their lives some way and get them to pay you. Well, most of our pharmacy clients, now some of them are startups or whatever that are trying to solve that dilemma still, but most of the pharmacies out there already have problem number 1 solved. They've got people walking in the door every day, large numbers of them.
This is going to have some basis in that the number of people coming in to a pharmacy area.
Absolutely. So then we can take step 2 and say, okay, we've got the people coming in. How can we get something into their hands that both benefits them and pays us what we're worth? So I'm a big fan of capitalism, as we probably all are if we're in business for ourselves. But in capitalism, it's got to be a transaction that makes sense to both parties, or we're not going to do the transaction. So if I'm selling something to Ben and it doesn't make sense to Ben, he's not going to buy it. If I can't sell it and make money, I'm not going to sell it. Well, pharmacy has gotten into a position where there's so much of it that our pharmacy owners are selling that they're not making any money on. So we have to change that narrative.
And I would add that it doesn't only add value to the person buying and the person selling. It keeps dollars in these local communities, Mike, and that's a huge thing. These online retailers, and you're seeing this mass exodus. PBMs are stripping communities.
All right, you're calling this the pharmacy of the future. Now, I'm going to call this a pharmacy of the past, and here's why. All right, now bear with me. Pharmacies way back when started off as medicine things. The guy would make their pills and things like that. And then across the country, profit margin went down. And so they start bringing in things like balloons and toys and Hallmark and post offices and, Western Union and all this kind of stuff. Now, in the year 2020, people say, okay, pharmacy should just be pharmacy, should just be health. Let's get rid of the balloons and the toys and the gifts and that, some people. But now you guys are saying that the pharmacy of 2030, that's looking to me like the pharmacy of 1970. Where am I off on that?
That's a great point. The pharmacy in 1970 didn't have the data that we have today, Mike, and that's really important.
That's interesting.
Yeah. We can actually evaluate profitability of these services. So we can actually say home health care, for example. Okay, there are pharmacies right now who have home health care agencies. Well, we believe that that is a legit thing that we can add. You've got an aging population who want to stay in their home and age at home. Well, they're going to need services. The average caregiver, I think we learned, is 281 miles away, family caregiver. So more than likely, they're going to be paying somebody to help. Well, we looked at the numbers. The average is about 26% net profit margin for that business. It's a little higher than the 2 or 3% we're seeing for independent pharmacies these days, by the way, just FYI.
Yeah.
So we can look at the things. The pharmacy insurance group, you're talking 40% net margins in this business.
People that need their Blue Cross or whatever, that margin is 40% for whom?
For the owner of the agency, so which will be the pharmacy owner.
Gotcha.
And we don't take any of that. This is what's really cool about the model. We don't take any of that. We don't charge a fee to set them up, and we don't take any of that. We actually get paid from the carrier to build agencies. So the more business that they do, the carriers actually pay us a small percentage.
This is finally this, right?
Mm-hmm. Yeah, absolutely, yeah.
Ben and Matt, you've been very patient with our questioning here, but we finally hit this, where part of this pharmacy with, let's say, 8 offices in it or something like that, one of them is healthcare. You guys would be paid to help set up the agency itself, and then the pharmacy would be, or someone in the pharmacy, a guy or a gal, running this, would be the agent that is making the agent's fee on this.
They're made what's called street level commissions. And this is silly, and I'll explain the silliness of it in a second. But we started it because pharmacy owners started calling us last year, last say 2 or 3 years, and they're very concerned that they're not going to be able to stay in the Medicare space because we've got one client, they're losing $30,000 a month on their Medicare business, and you $360,000 a year. That's just, at some point you can't sell enough DME or walkers or stools or seats for your shower to offset $360,000. You just can't do it.
You can't make that up selling bath stools.
Yeah, no, you're not gonna make it up. You ain't gotta sell a lot of canes. You gotta sell a lot of canes and walkers for that, and wheelchairs. So it started there. It's a crazy story how it all came together. But we met a Medicare agent, and he said, I didn't. This is word for word. He said, I didn't realize how much harm I was causing to independent pharmacies by pushing Medicare agent. I know that they're getting great service when they go into Tolson's, our local pharmacy here in town.
Yeah.
But Cameron showed me the reimbursement and the DIR fees.
Yeah.
And he said, I had no idea that I was actually doing this. I had no idea I was hurting these people. And so he said, I want to get Cameron licensed and let him get the commissions, because now you go from something that's not profitable to profitable. And you can continue to serve Medicare patients. And listen, they're already doing this anyways. Pharmacy owners, for the most part, using some of the software available in today's world, are already helping patients choose Medicare Part D plans. So why not just get paid for it? Why not make some money? You got to jump some hurdles and get some stuff done up front in order to be able to do this. But this is the silly part. Bring it back around. A Medicare agent can work with a patient for 1 hour and make $540 commission. And any owner out there who takes that Medicare patient is going to see them, 20, 30 times over the next year?
Right.
And lose money every single time you see them? It's ludicrous, the model at this point. Go ahead.
I had on Flavio that started iMedicare.
Yeah.
He was on a couple weeks ago. And when iMedicare came out, I was always under the impression that pharmacists legally could not recommend an insurance. And then secondly, I told Flavio that iMedicare was like deciding what bullet I wanted to have shoot me. You know, it's like,
Yeah.
I thought they all stunk. So it's like, I'm not going to recommend any of them, even if I could. I don't think I legally can. Even if I could, I wouldn't want to do it. How does this get around that? Is that a rule?
Believe it or not, we have not found any rules in any states that says you can't do it. But in order to make sure that we're maintaining the highest ethical standards, we're still going to recommend you give the information. And we train the agents, whether it's the owner or whether it's agents who work for the owner, we train them to give that patient the information, and then you let them choose. There's no conflict of interest, there's no steering, and it's definitely not illegal. I think the PBMs have been successful in really scaring us in some ways, Mike, because they sit there and tell us we can't do it, but then they put their captive agents in Walgreens or in Humana and do the same thing they tell us we can't do.
You're seeing that in chain pharmacies. They're having their agents there.
They're captive agents.
But they say it's probably not in the pharmacy or something like that, right?
So we've learned.
15 feet.
They're outside the pharmacy. But you got to be 15 feet, I think. You don't want to have this conversation behind the pharmacy counter. You want to be 15 feet out in front of it. So the same thing that they scare us from doing, they're doing themselves. So if it really was illegal, if it really was steering, if Medicare wanted money and they found out and they thought Walmart was steering agents to Humana, that's a captive Humana agents. You can only choose Humana. That is the classic definition of steering, if there is one. They would hammer them. They'd fine them because Walmart can write big checks, you know, but you don't ever hear about it. We feel it's absolutely the best thing for a patient to see you, an independent pharmacy, and have a conversation about their insurance. That's way better than going to Walmart. That's way better than going to an outside agent
who doesn't know, or even worse, couldn't care less about your pharmacy and is going to sell them the highest commission product.
In your vision of this, would this room then be staffed by an agent, not by the pharmacist, and the pharmacist wouldn't really even mosey in there kind of thing? It's like a separate, room?
Yeah, I think that a separate area of the pharmacy or a separate room, absolutely. Listen, when you look at the profitability of insurance agencies, there's a reason insurance agencies get sold for 3 to 4 times gross revenue, not 3 to 4 times EBITDA, by the way, okay? Because they're extremely profitable.
Yeah.
The value of a human being, they're more valuable as a full-time insurance agent than they are as maybe as a tech who's doubling as an insurance agent. So
yeah, I think that's the route that most of our people that have hopped on board with the pharmacy insurance agency is, that they're turning it over to somebody else. Sometimes it's a spouse, sometimes it's a child. Some of them will use a technician, and then some of them are just finding another health insurance agent to bring in to run this portion of it. Because the pharmacy owner also owns the agency, they're able to participate in some of the revenue on the back end, even though they're not actually doing the recommendation of the insurance product.
The pharmacy owner owns the agency.
Yeah,
Yes.
and so that's the clear winner in this whole thing. Most people are doing that now, so you don't have to dive in, head first. You can get yourself licensed in a tech and then work, go through annual enrollment this year and learn the kinks of it and how it works, and then start to bring on full-time agents. But we've got guys and ladies now who are thinking big with this. I got a call from a gentleman in Arkansas, and he said, I want the entire state of Arkansas. I want to put my agents in every single independent in Arkansas. Look at what they sell for in the profitability.
This guy that's saying that is the owner with agents, but you're talking about the pharmacy being the owner. So how do those two jibe?
We told this gentleman that probably weren't set up for that kind of deal, because what he was looking, he is a pharmacy owner and a multiple pharmacy owner. He wanted to put agents in his stores, and then said, hey, if there's any other person in Arkansas that doesn't want to do it, then I'll take it.
Oh, he was a pharmacy owner. He was saying he'd like to put his agents as a pharmacy owner in other pharmacies.
Yeah, with a non-compete, saying I'm not going to compete for your pharmacy business, but I'm gonna put your people in good plans for you. Oh, and by the way, I'll pay you rent. Now, there's some money you can make from this, and yeah. So I think the whole point is you can think really big with this and really create a wonderful business that is marketable, it has value, and it diversifies what you're doing, and then ultimately keeps these patients in their independent pharmacies, which is, again, what we feel is way better for the community.
This is the pharmacy of 2030. Are there any pharmacies of 2021 that have gone 9 years early and have done this?
Yes, absolutely. I think we have 75 agencies onboarding right now.
75 pharmacies that are becoming agencies.
75, yes, who are in the process.
I know, like, real estate, you have to work under someone for a year, this or that. Do they have the same thing with insurance?
They have to have what's called a general agency, which is what we are.
I gotcha.
The idea is to unite pharmacies and these insurance agencies under one banner, which is the Pharmacy Insurance Group.
I gotcha.
And to create a really powerful brand.
Gotcha. That
will be recognizable no matter where anybody goes. And if you think of like the State Farm model, okay, it's like that. So somebody will have a licensed Pharmacy Insurance Group agency, and so that's the vision. And for that, like I said, as a general agent, we get paid a little bit of money. It's a very small percentage, hopefully off a big pot, but a very small percentage. But that comes directly from the carrier. So there's no, when we talk, there's like, people are really surprised to learn that there's no fee for us to help. That 3 to 5% that we get paid, which is what it is, and we're completely transparent with every single one of the people we talk to. It's enough for us to invest in some training and some technology and things like that.
These agencies or sub-agencies, are they actually up and running now somewhere?
We have 4 up and running.
Nice.
It takes 6 to 8 weeks to get from point A to point B.
So I think that was the question kind of initially in terms of the process of getting set up. But do you have to go through some licensing? That's the one thing with the insurance commissions, they can only pay to a licensed agent. So both the agency owner,
gotcha,
who is usually the pharmacy owner, and the agent will have to be licensed. Then they're going to have to go through some specific Medicare training, which a pharmacist is going to blow through because it's fairly simple if you understand Medicare.
Right.
And then our training process is pretty extensive because there are a few things that we need them to do, but the main one is they need to understand all of the programs, and they also need to know that the agent represents the patient, not the pharmacy. So we have an agreement that they'll sign that says, when I put this hat on, whether I'm the pharmacist or another agent, that I'm helping the patient do what's in best interest of the patient, which part of that is the same thing pharmacists have been doing forever, getting their prescriptions where they get the best health care, which we know is at the pharmacy, the independent pharmacy. So they're going through all that process to make sure they understand what we're looking for there. And that takes 6 to 8 weeks. Some people will move through it faster. Some people will take a little bit longer.
Assuming all the pharmacy reimbursement stinks, they then know that they're still going to make money on the recommendation of 3 plans that maybe stink for pharmacy, but at least they're still going to make money on it.
Yeah, I mean, that's the thought process.
And even if it comes out to where the best plan has them preferred at Walgreens and not at the independent, then the pharmacy owner or insurance agent can say, hey, look, Walgreens is going to be a little bit cheaper for you. If that's your deciding factor, then that patient goes to Walgreens, but we still make the commission on it. By we, I mean the pharmacy group still makes a commission, so there's still money there. In general, we believe that the first thing that the patient and the insurance agent come to the conclusion is that we want to do what we can to stay in this pharmacy if possible, because we all know that an independent pharmacy gives better care than Walgreens or certainly than a mail order. So that's going to be the primary goal, but it's not going to work out perfectly for everyone, just like it doesn't now.
Does it cost the pharmacies money to set this up?
It does. It's very minor. I mean, you're talking a couple $1,000. There's
a licensing cost, which is about $100 for every state that you want to be licensed in. There's insurance exam, which is about another $100. You got a couple $100 in study materials for it. You need some E&O insurance. That's errors and omission, which in the insurance or financial services world that just protects you from doing something a little bit off the wall, putting your client in a bad spot.
That's a fancy word for mistakes, right?
That's right.
Yeah, that's the oops, I messed up insurance, yes.
So that's probably it. We have a CRM and a pharmacy insurance group email address and a secure VPN to make sure that nobody's getting hacked on their computer.
Gotcha.
So those total, like Ben said, about $2,000 to get up and running.
Do you guys have a formation, like a training fee, something like that?
We do not.
Most people doing this, well, anybody doing it, if they're aware of costs, can point to this couple $1,000s and say, all right, this was for this was for this.
Yeah.
You guys said it from the very start.
That's
You're
right.
getting paid by the insurance to set up these programs.
Yeah.
And this money is truly a way to get going.
Pharmacy owners in community pharmacies, they're so used to everything getting marked up on them and everybody
Right.
making money. So because there's this 3 to 5%, it's called an override that we get paid from the carriers, we actually called some owners and we're like, what do you think about this and this and this? And pretty much we're told we're tired of everything getting marked up and us getting not ripped off, but taken advantage of. And so we just said, you know what, we're going to charge everything at cost. And that's what we do. We charge everything at cost. What's really cool about this model, and I love this, and pharmacy owners are not used to this. They're not used to having a model where the people who are actually delivering it win when they win. It's so foreign of a concept.
Right.
So I've had a couple owners say, this can't be. You got to be making money somewhere else. I'm like, no. If we don't get you off the ground and get you across the finish line and get you making really good money with this, we don't make any money.
Yeah, so there's a couple things there. I think first off, the opportunity is it's still really good for us at Waypoint. We anticipate this going really, really well, and the dollars will be there. But the other thing is, we want it to be about the dollars staying in the community. And Ben and I are fortunate enough. The Lord has blessed us to be in a position where we don't need this to turn around and pay us money tomorrow or even 6 months from now. This is a long-term move on our part that if it goes well, which we anticipate it will, it's going to really help a lot of pharmacy owners. And long-term, we'll be rewarded for the effort that we put in now.
What's your biggest objection, do you think? Whether it's true or not, what do you think pharmacists' biggest objection to this? Some that you've heard and some that you're thinking that might be in their subconscious or in their conscious, but they're not voicing it.
You talked about one of them. It's this belief that we can't do it. That's a big one. Okay.
Gotcha.
When we go through this and we do webinars on this and we see like the chat field just starts filling up. How can you do this? You know, is this illegal? You know, you start getting all those questions. And I would say that's one. The bigger one though, it's this perceived lack of time. In our organization, we have worked diligently to eliminate I don't have time as an excuse. What I would tell pharmacy owners is you do have time. If you make this a priority, you can get it done and you can build $1 million or $2 million, $3 million asset. That is way more profitable than what you currently are dealing with in an independent retail pharmacy. But you have to make time for it.
We all have the same amount of time. So when somebody says, I don't have time, what they're really saying is, I'm not making that high enough priority to actually do. That's, like Ben said, the most vocal response is, I'm not sure if this is legal. Once we talk through that, especially if somebody that's concerned, if they're interested with the route of starting an agency and having somebody else actually make the recommendations, I think most people come on board with and get comfortable with that. But then it's a matter of, it takes 6 to 8 weeks. An insurance exam is not rocket science. It's not the pharmacy boards, but it's something you have to study for a little bit. You're not just going to walk into it and get a 70 or it varies by state what's required to pass. So there's a little bit upfront work, and that's a lot to put on pharmacy owners that already have a lot on their plate. But the back end reward we think will be well worth it.
What's amazing is when we first got into this, it was to solve this Medicare challenge that we're facing. But you start thinking about when you have the life accident and health license, you can do commercial insurance, you can do individual Affordable Care Act insurance, you can do life insurance. So you can really build an insurance agency, a full service insurance agency. You can't do property and casualty. You can't do your homeowners and automobile. And, we typically don't recommend that you do that because it's a very high service, low margin business. We're not looking at adding this to the pharmacy of tomorrow concept, this 2030 future, if it's not 25 or higher net profit margin. Because again, at some point, you're working really hard and you want to see the fruits of that labor. Well, Mike, think about the opportunity. Scott Amos, who's one of our partners in this, he rattled off how many types of insurance? It was like 40 different types of insurance that you have patients, and all you have to do, the challenge, is to help your patients understand that they can buy it from you now, that you can do both. And it's already happening with the Medicare side.
Scott, as a Medicare agent, said that he always felt bad for the pharmacy because somebody would come in with a printout of exactly what they need to do. He said, the pharmacy's already done my job for me. All I have to do, literally spend 3 minutes clicking through a few screens, and they're signed up, and I get paid for it. Pharmacy owner or agent in the pharmacy that actually picked it out didn't.
So
there's also been in my the idea that a lot of our pharmacy clients have health insurance. They have group disability insurance. They might have group life insurance. Well, all of a sudden, they can become the agent on that, and then they've just gotten reimbursed for their time by getting paid on their own benefits.
They can buy it for themselves, yeah.
Well, pharmacy, we've maybe been surpassed by maybe nurses or something, and because of some of the gag clauses with the damn PBMs and stuff, but they've always been, the trusted people. So is there anybody that you don't think would be in the market for this? Are you like, all right, as you're going down your list, it's like, we're not going to call Kelzer. He's an old fart that seems stuck in his ways. You know what I mean? Is there anybody that you don't think will be a market for this?
I think probably the biggest kind of feedback we've had for people that aren't sure if this makes sense are people that have a really small Medicare population. So we have a client that has a really nice pharmacy, but it's mostly compounding, doesn't have a lot of foot traffic. He thinks he's got about 200 Medicare patients. And we're talking through it. The numbers can still make sense, but they don't make as much sense as if he had 2,000 Medicare patients. Why
Medicare? Is it because commercial is already done by some bigger firms, or why just Medicare?
It's kind of the low-hanging fruit. That's where I think a lot of people are already making decisions at the pharmacy. So we think of that as the easiest entry point.
And the vast majority are all enrolled at the same time.
Oh, I gotcha.
Okay, so we can line up and get a bunch of patients at one time. So again, that's where the most need is. You got a very vulnerable population, which is our seniors. My grandfather got pushed to TRICARE mail order, and it was terrible. Mm-hmm. Mike, I'm convinced I'm not going to say he'd be 95 this year. But I'm convinced we'd have got a few more years out of my grandfather if he wouldn't have been pushed to mail order. And that's a long story. You can go to my blog and read it. It's really upsetting to me the impact that mail order had on our lives. And the fact that they say mail order saves money, and my grandfather had a stroke because his blood pressure medicine got messed up.
Yeah.
And spent, 20 days in ICU and then 20 days in skilled nursing. How much did that cost TRICARE?
Right.
So the Medicare population who needs to go to an independent where they know who they are, they know their history, is right now being systematically stripped from them and from the pharmacy being able to serve this population.
I want Ben to tell the story about our friend in Kansas who is on board. When any detractors say that I don't know that the pharmacist should be doing this, this is the story that I like to tell, but Ben tells it much, much better.
So we have an owner, and her husband is an insurance agent, licensed insurance agent, and he helped with Medicare enrollments this year. So he was sitting down, and they have a pharmacy counter, and right at the end they have a desk. So I don't think he qualifies for the 15 feet, but it's fine. Anyway, so he's sitting at the desk working with this patient. The patient's on a really high, really expensive blood thinner. Xarelto, I believe, is what it was. And in Kansas, their Part D plans either didn't cover it or it had a really high deductible.
Yeah.
So he actually, literally just looked over and said, hey, honey, can you check the cash price on Xarelto?
Yeah.
And they were able to choose a plan, carve out the Xarelto for a cash price, and save the guy about $1,800 a year. Now, tell me, there's no way that that's possible if we don't merge the insurance piece with the Medicare piece insurance with the care.
Yeah.
How's the captive Humana agent going to know that? How would I, as an insurance agent, know that unless I was having that conversation with the pharmacist or pharmacy owner?
I've got this guy in my business at the pharmacy, really sharp on all the insurance and stuff like that. And he tells these customers so much good information about their insurance. And I'm thinking, golly, I can't think of anybody better that if he could do insurance stuff, there'd be a benefit in getting rid of the middleman, because the insurance guy's not going to understand all the stuff that he would tell him. It's almost like I'd rather have a medical guy with an insurance license than an insurance guy knowing some medical stuff.
Exactly.
I mean, that message just gets lost. With all due respect to you guys, and you look like a couple of upstanding, smart guys, but it takes some brains too to know the whole medical side of things, right?
Absolutely.
As a pharmacist, and to know how that goes together. And so I'd rather have a mix.
That's the whole point behind it. Or not the whole point, but the initial point.
What I would tell you is it's easier to understand the insurance piece than is the medical piece. I'm just telling you.
Ben, I didn't want to say it. I didn't want to come out and say it, but that's what I was getting at. It's like the medical thing is so complicated. I'm not saying insurance isn't complicated, but the medical thing is so damn complicated with all the different stuff going on. It's like I'd rather my medical guy have an insurance license than have my insurance guy have like some, tech license or something like that, but not be living it.
I said it in a little bit of a different way, but getting an insurance license is not that hard, especially when you compare it to taking the pharmacy boards. So that tells you that there's a different level of education just in general. So plenty of really smart insurance agents, and I'm not saying every pharmacist is the next Einstein, but in general, having the idea that somebody can marry the two components really well makes sense.
And let's take education out of it. Let's just put in real life experience of customers crying or ticked off because they're not getting what they thought they got medicine wise and things like that. I think there's more real life stuff going on in the pharmacy than the insurance agent's ever going to really hear.
Absolutely.
They have experience, but it's in the insurance side of things versus there's probably more people crying in a pharmacy than crying in an insurance agency. Let's put it that way.
Sure.
I know you mentioned some different things in the pharmacy of the future. Are there other fields besides insurance that you see you guys playing a role in for the pharmacy of the future?
That's a great question. Mike, we'll continue to do the wealth management for the personal and the company, and we'll do the employer benefits.
But do you see yourself doing any other funnel for the pharmacy customers?
I'm really interested in the interface between veterinarians and pharmacies. I'm working with the American College of Apothecaries, and they've got a veterinary pharmacist kind of little offshoot association. So if you're really stay focused on the community, right, making the community a better place, it opens up just a world of avenues we can go down.
We don't have to have our hands in everything in terms of, like, we've met with franchise consultants and things like that.
Yeah, the International Franchise Professionals Group.
We want pharmacy owners to think different. That's what really this is about at the core, is if we can change the mentality of the pharmacy owner of today into thinking there's so much more I can do than just be a retail pharmacy, then that opens up so many doors. The pharmacy insurance group is one big piece. Ben's going to get a little bit more into the franchise, but there's literally anything that the patient needs in terms of healthcare, we can run through the pharmacy.
So mainly healthcare will always sort of be at the bottom of this, right?
Remember when you peel those layers back, it's still healthcare. It's still healthcare. The people are going to still come in with the idea I'm going to get my scripts filled. I'm still a pharmacy. But the idea is to really focus, to do real patient relationship management. We're calling it triage, where you sit down and have an appointment with that patient and say, what are your needs? Not just healthcare And you start to have that patient tell you what he or she needs, and then, hey, we've got the solutions in-house, or we're connected with people who can help you with that, and become that hub where people know I can go get what I need to be successful at that independent pharmacy.
Ben, with that then, do you think that is mainly going to be health, or do you think that other things can play into that? I mean, would you be telling somebody the best place to get their vinyl siding done? The reason I ask is because that separates it from my early question of back in the 1970s. The 1970s was like, all right, helium balloons, a post office, and Hallmark cards. How do those go along with the pharmacy?
Like home remodeling and bath remodeling.
Well, that certainly plays a role with the physically challenged.
Yeah, physically challenged. And when you start researching it, most accidents happen in the bathroom.
That's right.
Most seniors fall in the bathroom, and they want to stay in their home. Or like my grandmother has that little that chair that goes up the stairs, and so installing those.
And that makes sense. That's all a health-based. Health infiltrates everything.
But listen, it can be whatever we want it to be. I have a pharmacy right now, and they are considering a mathnasium or similar type franchise to do math tutoring in their pharmacy. The concept is it's the health and wealth of the community. That's really, if you think about the health and wealth, right? We want to take care of their health, but we also want to keep more of their wealth in the community because it provides economic opportunities. It's so much better allocated locally than it is by these big national behemoth companies. So the idea is if we really go in to take care of the needs of the community, it may be health related. It may be, it could be whatever we want it to be. And Matt brought up the International Franchise Professionals Organization. And that one is really important because pharmacy owners do not have the time to create new models, to create new businesses. Mike, that's like me asking you to start a home health care agency. You're going to look at me like, what are you talking about? There's no way I could add that to my plate. Well, franchises. They have the systems in place. And here's the great thing about the International Franchise Professional Groups. There are other ones out there, but the one we're partnering with, Red and his team, they will provide a franchise consultant. And you don't pay a dime to evaluate a franchise. And that's really cool. When I found that out, it became really clear to me that the franchise model was going to be really, really important. So when you're looking at a home healthcare agency, instead of starting one from the scratch, you can consult with a franchise consultant. And if you decide to put a home healthcare franchise in your business, the franchise will pay the franchise consultant. So it doesn't cost you a dime.
When people think of franchise, they think that they're going to be bringing in, wearing a silly hat and selling, Aunt Janie's cookies or something like that. But there's a million franchises, and a lot of them might easily fit in a 15 by 15 office or something like that.
You said it better than I could say it. Yeah, I mean, you literally could put a desk and run with the technology. I was looking at a franchise the other day about helping kids. There's a big gap now with the COVID and learning. We've had a generation of kids who we got to catch them up now because they've been, so if they did remote learning, this is not the same. Well, so there's a franchise that's been born. Now, again, I was just looking at it because it looks really cool, but you can run this franchise with 3 computers. So the idea is we can really start to work and meet the needs. Now, we're going to have certain things that we know work well in the pharmacy model that we'll bring. But like Matt said, the goal is to get pharmacy owners to start to think differently about the model. Where can we make a difference with patients and make money and not deal with a third party for reimbursement?
Someone listening to this might say, full speed ahead with pharmacy. It's not working, but I'm going to try to make it work out. And they might say, I'll never have a separate little business in my business. My business is the business. Well, that's fine. But if they go out of business and then they've got a building sitting there And then they're thinking, do I go work for somebody else or do I try to do something else? Then they do something else. Before you know it, they open up. They've got these little offices. They're a pharmacist still, and they're doing what you're saying. My point is, think about it maybe before you go all the way down, you lock the door for a week and then decide how to open it up again. Maybe there's a way to do it without locking the door for a week.
Yeah, and I think that's the challenge. Because there's no prototypical independent pharmacy. Yeah. They're all shaped differently. They look differently. They have different patient populations. So, I mean, that is the challenge behind this. So if you get into this concept, and I read a great article the other day, and it was in one of the pharmacy magazines, and it was talking about pharmacies have to transition to patient relationship management. And I love that. I love that idea because you're now starting to expand your services outside just a pharmacy. You're managing. So when you look and you start to segment your patient populations, if you realize, hey, I'm 50% Medicare. Okay, well, we need to find something that our Medicare people, our aging people want, because 50% of our business is underwater. And, or we find out, like Matt said, 10% of our patients are Medicare patients. Okay, well, that we're going to look for different things to put in that model. So the key is to have a process that somebody can tap into where they can do the evaluation of their patients and then find the components that will make sense to add to their pharmacy of tomorrow.
I hope that people who've listened to us chatting here, at minimum, this will get them thinking. They might be totally against what, I don't think so, but they might be totally against what you're talking about here. But hopefully then if you're against it that much, you're at least saying, I'm against it because I think this is going to happen in 2030. And then we've done our job today of having people think about 2030 regardless of what they think their answer is.
I've never lost hope that we're going to win. I know that good conquers evil. The light always conquers darkness. I've never given up hope that we're going to win this war against the PBMs. I've never given up hope, Mike, on that. The thing that scares me the most is what's going to be left on the other side. And so that's what's driving this whole idea of the 2030 future and the pharmacy of tomorrow. We have to do things to adapt. The pharmacy model has been around for a long time. Listen, our company, if I told you in 20 years, this is our third time reinventing ourselves, and third time. Things happen so fast in our model. Every 6-7 years, we're reinventing our model. And it's exhausting. It's a ton of work, but it's a requirement if we want to stay in business.
It takes continual change. And just because Mrs. Smith comes in and tells you how much she loves you and how much she loved your grandpa and your dad and all that, it's like, that's good. But we can't just be stuck in the same way because Mrs. Smith said that. We also don't have to really get away from it because of Mrs. Smith's trust in us and trust in our grandparents and our parents. We can use that to our advantage. We can't stay like we were, but we can still use that trust to our advantage, what you guys are talking about today.
That's the thing that makes this whole thing work. It's the trust and the influence that pharmacies have built.
Pharmacists have still taken care of people for the last 10 years when they've been getting screwed, that if they make some money, unless they get greedy and don't know how to handle it, they're going to even take more care of them if they maybe get paid again for some of that stuff. It's crazy.
We have a saying before we walk out of our office. It's above our door, and it says, a journey of 1,000 miles begins with one step. So I think that's really important, that surround yourself with good people who care for you and who walk with you on this journey. And there's nothing in the world that we can't accomplish together for the betterment of families and communities across America. I think, Mike, you're committed to it with this podcast to try to help pharmacies. I think we're all in this together. I think we're better together doing this. There's a great speech by Teddy Roosevelt. I wrote it back in the late 1800s called The Man in the Arena. It wasn't very politically correct, but he wrote it's called The Man in the Arena. And it's so important that we try, that we're in the arena. We don't want to be with the poor, he called them the poor, timid souls who neither know victory nor defeat because they were sitting on the sidelines and they refused to get in the arena.
Yeah.
And that's my challenge to pharmacy owners, community pharmacies. Get in the arena. You've got to be in it, whether it's politically, whether it's working on your business model, whatever. Get in the arena. Don't be that poor, timid soul who just didn't try because you thought it was insurmountable or you thought it's not going to make a difference. And because you do make a difference. You matter to the people you serve, to the communities you serve. You matter to them. And because you matter to them, you matter to us. And that's why we're always going to fight with you.
That's my love of the podcast here, is because sometimes we come across things in the industry and either you got somebody who's just bitching up a storm, or you've got somebody that is all positive about how people are killing it, and they're doing great. It's neat to have the length of a conversation because that's life. It's got its ups and downs. Just by chance, when COVID hit is when I started working more in the pharmacy. The last 5 years, I wasn't there very much. And boy, you wouldn't know it by the remuneration that we're getting, but pharmacists are really important. Being out there now, we don't do vaccinations ourselves, but all the pharmacists that are vaccinating, I was talking to someone else. They said they didn't know if the SCOTUS, Arkansas determination they made would have gone through without COVID, without seeing pharmacists out there. So who knows what's going to come.
We have hope. Listen, what if we transform the model? We're providing this wonderful service with this wonderful profitability, and we win, and we get the wins that bring some kind of sanity back into the reimbursement model where or the DIR fees, we get rid of them or whatever. And just think about that. That's my hope.
When I was a kid, I always thought, if I ever got cancer, I'd be the best cancer patient. I'd be nice to all the nurses, and I would try to bring some levity to it and stuff. And as I get older, it's like I'd be the worst cancer patient.
Yeah.
I would just be an ornery son of a bitch after like 8 hours in my hospital bed. But here's the point. With cancer, if you could take a cancer diagnosis, it's like try to find something just 6 months out. Because in 6 months, who knows what's going to happen? That's like with our businesses. Sure. Try to hang on for 6 months. You don't know what's going to happen. You don't know COVID. You didn't know maybe that PPP might have helped out or some other loan. Or you don't know all that stuff. So just hang in there for 6 months. It comes in steps. You can't see it all, but hold on for 6 months and there's going to be some life there.
And what's really cool about when you start having the conversation at the level we're having it, it's just you get filled with hope. There are a lot of really good people who want independent pharmacies to make it. That's really important. There are a lot of people that want you to make it because they want to keep making money off you. There are those guys too. But there are a lot of really good people. I call them friends. Yeah. Friends to pharmacies who believe in independent community pharmacy and what you mean for and what you stand for and who you are. And you have to have hope. That knowing that there are people out there, there are people who are rooting for our business to succeed, and because they know the impact we're trying to make in the world. And when you know that you've got advocates on your side, people who are pulling for you and fighting with you in the arena with you,
moving forward and trying to make change. And you guys have taken us out 10 more years, so way to go! All right, you guys, keep it up.
Thanks, Mike.
Yep, thank you so much. We enjoyed it.
Thank you very much. Talk to you again soon. You've been listening to the Business of Pharmacy podcast with me, your host, Mike Kelzer. Please subscribe for all future episodes.